nightmare for any obstetrician, a complete perineal tear. So I, Dr. Aarti Sridhar, will be moderating this session. Over to Arun to start with a lamp lighting. Arun.
It is why the reason why the cases are probably the biggest data breach in decades. Also, there are the systems for
Dr. Aarti?
Not able to hear.
just be an actual
Sir, I was with Dr. Karishma. She had some
Yeah.
issues in joining.
Has she joined?
So,
Yeah.
Dr. Karishma?
There's some other webinar going in the background, I suppose.
Oh, good evening.
Not able
Good
to
evening,
hear.
sir.
Good evening, Dr. Karishma.
Good evening. I'm sorry I was not able to join.
Yeah, welcome to the webinar, Dr. Karishma.
Good evening, sir. Thank you.
Shall we proceed, Dr. Aarti?
Yes,
better
sir.
to proceed. Yeah.
So, after invoking the blessings of the Lord, we would like to proceed with today's webinar. I would like to invite our chairperson of Urogynec Committee, Vijay Kumar sir, to take over the proceedings.
Thank you, Dr. Aarti. Good evening to all. So, this evening it has become a very pleasant evening, very pleasant surprise. Dr. Hiremat sir has joined this webinar. So the reason being that the topic itself is so interesting. As Sir Dr. Hiremat mentioned, the perineal tear is less spoken but more suffered problem in the society. So, Dr. Sudha Patil, who is HOD in Akash Medical College, must be knowing about this case. There was a case we got 15 days back who had come for hysterectomy for AUB. But when I examined her, there was a significant perineal defect. So the moment when I asked her, how are you living with this complete perineal tear? Immediately the tears started pouring out from her eyes. So there was no words expressed from her except the tears pouring out. This itself will tell that there are many such women who are suffering silently from the complete perineal tear. Maybe that they are ignorant or they might have not approached the doctors at a particular time. As we all know that the complete perineal tear is because of the perineal injuries caused during the childbirth. Most of the time, the specialist will identify and repair it, but sometimes it may go miss or it may be neglected, leading to the anal incontinence in future. So, to discuss about the anatomy and the evaluation of the perineal tear and its management, we have the eminent speakers and who will be introduced by the chairpersons. So, before that, I welcome our the patron, chief patron, Dr. M.G. Hiremat sir. I also welcome President Dr. Rajeshri Palladi, Secretary Dr. Shobha Gudi Madam. I also welcome our past president and the president-elect, and I also welcome other office bearers of the Kasoga. So we will move to the scientific webinar on the complete perineal tear. Over to Dr. Aarti.
Yes. Sir, Before we start with the webinar, a few words by our President and Secretary.
Yes.
Yeah.
Over to
Namaste.
you, ma'am. Yes.
Good evening, everybody. Namaste, Hiremat sir, and congratulations to the Urogynecology Committee, Dr. Vijay Kumar and Dr. Aarti. Sir, I must say that the Kasoga family has been so committed to the webinars by the committees that consistently now, this is the 15th or 16th webinar without fail, that on every Wednesday we are doing a webinar right from April, sir. So such is the beauty of the academic commitment of the committees that every time Wednesday 8 to 9 we continue to have our learning programs, and maybe as simple or as basic as perineal tear, but we know that it is so worrisome for everybody, just as Vijay Kumar sir mentioned about a case scenario that many times we come across this because something which the woman shies off and something which the woman has to live with. I congratulate the team of urogynecology for choosing such eminent speaker and welcome Dr. Karishma and Dr. Mandeep for accepting our invitation from Kasoga and being here with us to share our knowledge. Over to you, Dr. Shobha Gudi. And sir, we look forward to more such activities from the Urogynecology Committee and also in the Kasoga conference. I wish Dr. Hiramat sir has to please say a few words.
Yes. Good evening to everybody. In fact, this is the second program I have joined for Urogynec for various reasons. Today I just saw the in Kasoga
Group
that today evening at 8 p.m. there is a topic on perineal tear. I thought I must join. Thank you, Dr. Vijay Kumar, selecting this very simple and very complicated topic. Now, why I'm telling very simple and very complicated is that we give to the juniors the deliveries, interns, first year PGs, and they end up with perineal tear because for various reasons, or even simple precipitate labors, difficult vaginal deliveries. Just I have come back from Mysore, where I have given late Dr. S.N. Kaulgud Memorial Oration, and Dr. Kaulgud was a great obstetrician. And I have seen many perineal tears when he was delivering because he was using keel and forceps, because he was using mid cavity forceps. In all these situations, the perineal tears were very high and extensive perineal tears. And sometimes perineal tears were involved with rectal injuries. Imagine the extent the instruments used to create havoc in the previous era. Luckily, we are not having such deliveries now because cesarean has made it more easy. Still, there are the perineal tears are seen. If they are repaired properly at the same sitting, it's well and good, and that will be the best treatment. But many a times, what just now Vijay Kumar said, that she has come for hysterectomy and he has seen such a bad perineal tear. So woman will remain with a perineal tear for a very, very long time, and everybody neglects because it is not a very important area or important operation. I think we have to care for that. I think rightly Vijay Kumar has selected the one of the best speakers in this area, Dr. Karishma and Dr. Mandeep, and they will be doing the justice to the topic. And I do not want to take much time of yours. I wish a grand success for this webinar on perineal tear. Thank you for giving me this opportunity.
Thank you, sir.
Thank you. Thank you, sir. Thank you, sir. Aarti, I'll just take few seconds. I'm really
Yes, ma'am.
happy. I'm really delighted that Urogynec committee is doing so well, and I'm really thrilled that the president has inspired all the chairpersons to commit themselves to Wednesdays to bring us very quality programs. Urogynec is a specialty which we have to nurture and learn and teach and understand better, because if we don't, then like endoscopy, everything, it will be taken away from us by urologists. So we should kind of protect this as a passion and make it completely for a gynecologist, and develop urogynecology training programs. So Vijay, you have got a very long road ahead of you. We expect you to do more in this field, and today's topic is very well explained by Hiremat sir and Rajeshri. that there is a lot of silent suffering by women, and you really beautifully opened the program with the case that you have encountered. We have all seen such patients, and they will live with various degrees of incontinence and discomfort and absolutely destroyed sexual life, even though the partner may not feel it, but for her it will be a very bad experience. And I think prevention uh, it should be highlighted in any training program, and I can see that you have prepared for that as well. So all the very best to this, and may you continue to do such great programs. Thank you for the opportunity to speak. Thank you very much.
Thank you, ma'am. Thank you, Rajashri ma'am, Shobha ma'am, and Hiremat sir. So, as obstetricians, we all aim for an atraumatic delivery, but these do happen. What matters is how quickly we recognize them and how we repair them. So, today we have our eminent speakers dealing about this. And our aim today is to make every participant more confident in identifying the third and fourth degree perineal tear and performing a tension free anatomical repair. So, Arun, can we have the CV deck? I would like to invite the chairpersons for the first talk. So, we have Dr. Akkamahadevi Hiremat. Ma'am has various awards, recipient of Karan Gupta Award, DC Dawn Award, publications, special interest in gynec endoscopy, urogynecology, and clinical research. She is a senior consultant at Sri Madhusudan Sai Institute of Medical Sciences and Research, Mudenahalli. We welcome you, ma'am.
Thank you, ma'am. Thank you so much. It's a great initiative.
Yeah. Arun?
Yes, madam. Second CV, ma'am.
We also welcome Dr. Sudha, who is the professor and head of the Department of OBG at Akash Institute of Medical Science, who has over 18 years of experience in the field of healthcare. She has been a faculty member in various medical colleges, has wide experience in high-risk pregnancy management, infertility, and various gynecological surgeries. Over to you, ma'am, either Sudha ma'am or Akkama Devi ma'am. Kindly introduce our speaker for the day.
Yeah. I'll be Dr. Karishma Tarini, consultant. She's a consultant urogynecologist, and she is at the Center for Urogynecology and Pelvic Health in New Delhi. And she is a member of Urogynecology Committee and other things. And she has a lot of publications in national and international journals, and reviewer of for International Urogynecology Journal and Indian Journal of Urology and Indian Pediatrics. We welcome you, madam.
Thank you so much, ma'am. I'll share my slides now.
Sure. Please.
Yes, ma'am.
Please share.
Are my slides visible?
Yes.
Yes.
Yeah, I'll just put it on slideshow.
Yes.
First and foremost, I would like to thank Dr. Vijay Kumar and all the entire organizing committee of Kasoga for inviting me for today's webinar. It is indeed very delightful for me to be here in this August gathering. The topic that I have been allotted is applied anatomy of the anorectal complex and the perineum. Everybody, including Dr. Vijay Kumar, very rightly said how complete perineal tears and fecal incontinence contribute to a woman's silent suffering. Like it is as it is important to understand how to diagnose and repair the complete perineal tear, I also believe that as gynecologists and urogynecologists, it is very important for us to understand the anatomy of this area and how anatomy contributes to fecal continence. So that because a lot of times you will see that even after repairing a complete perineal tear, the patient ends up having fecal incontinence later in her life. So to understand how the different components of anatomy work together to maintain fecal continence will help us understand and prevent fecal incontinence later in the woman's later stages of life, even when a complete perineal tear has been repaired successfully at the time of her delivery. So with this note, I would like to proceed further. Like I said, the objectives of today's lecture are to understand the anatomy of the perineum and the anorectal region, to understand what a complete perineal tear, what perineal tears are, and what is the classification of complete perineal tear, what are the different structures involved in each grade, and what are the maternal risk factors which predispose to complete perineal tear. Because if we understand the risk factors, we can make arrangements and we can counsel the woman in the antenatal period. We can make decisions for her intrapartum course and observe her accordingly once the delivery has happened. So let's start with this area, this diamond shape area that you can see on the screen. This diamond shape area is called the perineum. It is divided into two parts, the urogenital triangle and the anal triangle. Perineum, we know, is bounded posteriorly by the coccyx, anteriorly by the pubic symphysis and the istiopubic rami, and laterally by the ischial tuberosities. Coming to the urogenital triangle, the urogenital triangle is further divided into superficial perineal pouch. Now, what are the contents of superficial perineal pouch? Superficial perineal pouch consists of the istiocavernosus and the bulbospongiosus muscle and the superficial transverse perineal muscle. Now, both bulbospongiosus and superficial transverse perineal muscle are often injured when you give an episiotomy, and they have to be repaired. Sometimes when we are looking for when we are trying to repair a complete perineal tear, we suture the superficial and deep transverse perineal muscles, mistaking them to be the external anal sphincter. That is why correct knowledge of these muscles which lie in the superficial perineal pouch is extremely important. Other than that, other contents of this pouch are the Bartholin's gland and the vestibular organs of the female. Coming to the deep perineal pouch, in the deep perineal pouch, we have the sphincter urethrae, the compressor urethrae, the ureterovaginal sphincter, and the deep transverse perineal muscles. Like I said, superficial and deep transverse perineal muscle help in, they are both parts of the perineal body, and they are often mistaken as external anal sphincter during the repair. So one has to be very careful when we are repairing a complete perineal tear. Now coming to the anal triangle, we know that the anal triangle consists of the anal canal, the anal sphincters, the perineal body, this golden structure here, and the istiorectal foci. Now, this perineal body is nothing but a fibromuscular structure, which is very important for the anatomy of our pelvis. Why? Because it forms a level 3 support of the pelvis, and it helps in redirecting the abdominal force and dissipating gravity to prevent any expansion of the urogenital hiatus. And also because levator ani, bulbospongiosus, deep transverse perineal muscle, and the external anal sphincter all attach at the perineal body. So whenever you are doing a complete perineal tear, reconstitution of the perineal body is extremely important. Similarly, when you're doing a prolapse repair, at that time also reconstitution of the perineal body is extremely important. This is a patient who has a shortened perineal body, and this is something like the case that Dr. Vijay Kumar just described, a woman with absent perineal body completely. This is also known as the cloacal deformity. Such patients may often present with fecal incontinence or incontinence to gas or liquid stool. Now, after the anatomy of the perineum, let's move to the anatomy of the anorectal junction. Now, as a student, when I was studying during my years in gynecology and then during my fellowship, somehow I always found the anatomy of the anorectal area to be very confusing and very difficult. But because when we see a diagram like this, it is very difficult to understand what is happening where. So I've tried to simplify the anatomy of the anorectal area for you. Now, the anorectal area consists of the rectum, the rectum and the anal canal are the terminal parts of the gut. So it is the rectum that further continues into the anal canal. This anorectal junction is marked by the presence of puborectalis muscle, which is a part of the levator ani muscle. Now, this length of the anal canal from the anorectal junction to the anal verge is called the surgical anal canal. That is the length that we take when we are surgically exploring the anal canal. The anal canal is further divided into an upper anal canal and a lower anal canal by means of a pectinate line or a dentate line. Now we will understand from where this dentate line came when we understand the embryology. But this is the upper anal canal and the lower anal canal. Now the upper anal canal is nothing but a continuation of the hindgut. That is, it's continuation of the rectal, the rectal area. So here the epithelium is folded into these longitudinal crypts or longitudinal folds, which are also called as the crypts of Morgagni. Now, why are these crypts important? Because firstly, they have these vascular cushions or the internal hemorrhoidal plexus, due to which when you look at them through proctoscopy, this area appears bluish. Also, this area has glands. These glands produce mucus. Now, these vascular cushions here and the mucus helps in maintaining the coaptation of the upper anal canal, that is, keeping the anterior and posterior anal wall closed, so that the contents, the seal is maintained, the continence is maintained. So when we talk about anal continence, these cushions and crypts of Morgagni also play a role. Now let us understand how this upper and lower anal canal came into being. So the hindgut and the ectodermal fusion, the endodermal and the ectodermal fusion happens in the embryological period, and there is anal membrane here. This later gets converted into pectinate line, and the region above the pectinate line is called the upper anal canal, and the one below is called the lower anal canal. This upper anal canal is a derivative of the endodermal part, and this lower anal canal is a derivative of the ectoderm. So the epithelium in the upper anal canal, because it is a derivative of the endoderm, is simple columnar epithelium. That is why this area has glands and crypts, because columnar epithelium is having glands and crypts is basically native to columnar epithelium. Now, in the lower anal canal, because it is ectodermal in origin, the epithelium is stratified squamous epithelium. That is why this area is also called as the anoderm. And like any stratified squamous epithelium, this area is very rich in nerves. And these nerves have tactile and nociceptive sensation. This is again very important in continence, because these nerves are able to pick out what are the contents of the anal canal. Is it gas, is it liquid, or is it solid? That is why you may be listening to this lecture and you may feel like passing gas, and you may pass gas, but you will not leak any liquid or solid stool, because your anal canal has a brain of its own. It will not allow any stool to pass, but it will allow the gas to pass. That is why this lower anal canal, which is extremely rich in nerves, is extremely important in maintaining continence. Now, let us look at and this pectinate line is known as the mucocutaneous junction. The blood supply of the upper anal canal comes from the superior rectal artery, and the lower anal canal comes from the inferior rectal artery. Similarly, the venous drainage of the upper anal canal is through the superior rectal vein, and the lower one is through the inferior rectal vein. And here we have a portocaval anastomosis at this area. Now coming to the nerve supply. The nerve supply of the upper anal canal is through the inferior hypogastric plexus, which is basically autonomic nervous system, and it is only sensitive to stretch. That is it is not sensitive to any kind of pain or pressure or anything. Whereas the nerve supply to the lower anal canal comes from the inferior rectal nerves. It is somatic supply and it is sensitive to pain. That is why any hemorrhoids in this area external hemorrhoids in this area are painful. Now, coming to the anal sphincters, again, a very important concept in maintaining continence. Now, the structures which are the muscles which are involved in maintaining continence are first and foremost the puborectalis muscle, which helps in forming the anorectal junction. Now, puborectalis muscle forms a sling which pulls the anorectum towards the pubic symphysis, creating an 80-degree angle between the anorectal junction, which helps in maintaining continence. That means that the anorectal angle is like this. So whenever a patient has to pass motion, the puborectalis relaxes, the angle straightens, and then the motion is passed. So puborectalis plays a huge role in maintaining continence. Then next is the internal anal sphincter. The internal anal sphincter is present in the upper two-thirds of the anal canal. It is nothing but an extension of the circular muscle fibers of the rectum which come down. Then you have the external anal sphincter, which has a subcutaneous component. That is why you can see these creases on the skin, because there's a subcutaneous component to the external anal sphincter. Then you have a superficial component and you have a deep component of the external anal sphincter. The deep component of the external anal sphincter, the internal anal sphincter, and the puborectalis muscle together form the anorectal ring. This anorectal ring is what you feel when you do a PR and you feel a muscular band where the angle is changing. So this anorectal ring together helps in maintaining continence. Now, to differentiate between internal anal sphincter and external anal sphincter, internal anal sphincter, because it is a derivative or an extension of the circular muscle fibers of the rectum, it is involuntary, it's a smooth muscle. External anal sphincter, on the other hand, is voluntary and this is a skeletal muscle. The internal anal sphincter is present in the upper two-thirds. The external anal sphincter surrounds the entire length of the anal canal. It is supplied by the IAS is supplied by the inferior hypogastric plexus. We know this is supplied by the inferior rectal nerve, the perineal branch of S4. This looks whitish, looks like white meat when you are repairing a fresh complete perineal tear. You will see. Sorry. It is very important to be able to differentiate between the external and the internal anal sphincter. The internal anal sphincter looks like the white meat, and the external anal sphincter looks beefy red. That is, looks like the red meat. Internal anal sphincter is responsible for 70% of resting tone. External anal sphincter is responsible for 20% of basal tone. Internal anal sphincter relaxes only for short intervals. That is what we know as the recto-anal inhibitory reflex. Whereas internal anal sphincter can voluntarily relax or contract. Now, how the continence is maintained? What is the anal lock? So puborectalis muscle is contracted tonically and causes acute angle of recto-anal junction, that is continence to solid stool. Internal anal sphincter is non-voluntary tonic contraction, ensures automatic closure of the anal canal at rest. 60 to 70% of the resting tone is contributed by IAS. External anal sphincter increases anal pressure when there is a change in the abdominal pressure. If you cough, you will feel your external anal sphincter suddenly contract. It takes little part in relaxation. 20% of the continence is maintained by this. The expansion of anal cushions that we talked about and the crypts of Morgagni contribute to another 10 to 15% of continence. And rest little bit is by the reflexes. Now with this, let us understand what a perineal tear is or perineal trauma is. Any trauma to the perineal area that is incurred at the time of delivery is called a perineal trauma. It is classified into first degree, second degree, third degree, and fourth degree. First degree when it involves only the skin. Second degree when it involves the skin and the perineal muscles, the superficial and deep perineal muscles. Third degree when it involves the anal sphincter, and fourth when it involves the anal sphincter and the anal and the rectal mucosa. Now, grade 3 anal tears are further divided into 3A, 3B, and 3C classification. 3A is when less than 50% of external anal sphincter is involved and internal is intact. 3B is when more than 50% of external anal sphincter is involved, IAS is intact. 3C is when both the sphincters are involved, and grade 4 is when both anal sphincters and rectal mucosa is also involved. This classification is extremely important because if you misdiagnose, if you classify a 3C as a 3A and repair it like a 3A, then the patient is bound to have incontinence, fecal incontinence later on. That is why correct diagnosis, which is only possible when you understand what the sphincters are and how the sphincters look when the tear is there, then only you will be able to repair it properly. Now, looking at the risk factors, first of all, complete perineal tears have a prevalence of 0.5 to 2.5% of vaginal birth. There are multiple risk factors which are involved. We will understand each of these risk factors separately. It is important to understand the risk factors because then you can counsel the patient in the antenatal period itself. You can do appropriate labor management and you can take targeted preventive measures. Now let us look at the maternal risk factors. The maternal risk factors are maternal age, increased age more than 35 because it impacts the tissue elasticity. Nulliparous women are at a higher risk. Obese women are at a higher risk. Women who have previous history of perineal trauma are at a higher risk. Variations, maternal race and ethnicity can also impact. Asians are at a higher risk than Western population because tissue characteristics vary between different populations. Now, obstetric risk factors are instrumental deliveries, forceps more than vacuum. Sir was just telling us about various forceps deliveries and how they would often lead to complete perineal tears. Fetal head position, occipito-posterior, is often associated with complete perineal tears. Prolonged second stage of labor and augmented labors have a higher risk of complete perineal tear. Now, labor-related risk factors are the technique of giving episiotomy. Episiotomy should always be given at an angle of 45 to 60 degrees. A median episiotomy or an episiotomy of a shorter angle should not be given. Proper perineal support. The pushing technique. Sometimes patients just hold their breath and they keep pushing. That kind of pushing technique should not be allowed. This is called the closed glottis technique. The open glottis technique of pushing, where the patient shouts and then pushes a little, shouts and then pushes a little, is one that is advocated. It is also called the controlled pushing or controlled bearing down. Delivery mechanics such as rapid uncontrolled delivery, precipitate labors are often associated with complete perineal tears. And delivery position. Trust me, lithotomy or dorsal lithotomy position is the worst position for normal vaginal delivery. Sitting position, upright position, squatting positions are associated with lesser complete perineal tears. Now, this is a chart which shows the relative risk. Vacuum extraction has a 2.5 times risk. Forceps non-rotational 4.2, almost double of vacuum. Forceps with rotation, almost 3 times that of vacuum. Thankfully, we are not using rotational forceps anymore. Median episiotomy 3 times. Birth weight more than 4 kg 5 times. And age more than 35, almost double of a low risk primi gravida. So with this note, I would like to conclude by saying that the only thing that, one of the things that mark humans' superiority over other primates is the presence of hands. But anal sphincter, when compared to the hand, is far superior. Why? Because if you place into your cupped hand a mixture of fluid, solid and gas, and then through an opening at the bottom, try to let only the gas escape, you will fail. Yet anal sphincter can do it. A muscle like this is definitely worth protecting. Thank you. If there are any questions, I would be happy to take them.
Fantastic. Very good.
Thank you so much.
Nice
Very
presentation, Dr.
lucid,
Karishma.
very clear. The basics were very clear, madam. It was amazing.
Thank you, ma'am.
Dr. Karishma, this topic and talk was very, very fine description of the anatomy. And I think the postgraduates will be greatly benefited by this. I'm glad we have the YouTube link for this and we will circulate in the HOD group so that this can be available for all the teachers as well and the postgraduate students. Thank you.
Thank you so much, ma'am.
Thank you, ma'am. It was a wonderful talk. Fantastic presentation. So we will, any questions? So should we take it in the end?
Yes, I
have
think
one. I have one point of discussion. Now, when
Yes, ma'am.
Karishma, you were very specific about the technique of pushing. Now,
Yes,
this has not been kind of propagated much or not been trained much, either by the midwives or the obstetricians, not understood much. So, have you done that? I mean, do you actively tell that? Can you throw some light on that? What
yes, ma'am.
exactly you
So,
tell the mother?
yes, ma'am. First of all, normally, I have done most of my training in Safdarjung Hospital in Delhi. And anybody who has ever been to Safdarjung would know that it's the busiest obstetric hospital in the country. We have the maximum number of deliveries in the country in Safdarjung Hospital. Now, the usual thing is when a patient is shouting, what do we say? Chillao mat, don't shout, and just stop and just keep quiet and keep bearing down. I think this statement itself is wrong, because when a patient is shouting and does not hold a breath while pushing, this is called open glottis technique of pushing. Open glottis technique of pushing, when the patient stops to take a deep breath, makes the whole process of pushing controlled. Whereas when she is holding her breath and constantly bearing down, that is constant pressure on the muscles. This is closed glottis technique of pushing. This is associated with higher rates of perineal tears as compared to open glottis. And even if we eliminate the shouting part out of it from it, if you are asking the patient to bear down, then ask her to take. You can stop her in between from bearing down. She bears down a little, then she stops, then she bears down a little, so that the pressure on the muscle is uniform and not constant and sudden.
Yeah, what we make sure is whenever there is a contraction, that is when she exerts the pressure. During the contraction and during relaxation, she should not push. This is what we say. But yes, what you're saying is very interesting, and I think you must read more about this.
There is
And
an excellent Finnish paper, ma'am, if a study from Finland, in which they use a technique called the Finnish technique of
correct, I
delivering
have
the
heard
baby
about
head.
it. Correct.
Yes,
Only today I'm knowing. Yeah.
and in that technique only they have spoken everything about the position of delivery, the open and closed glottis pushing techniques. It's an excellent paper to read, ma'am. Anybody can.
That's a wonderful reference. Thank you very much. Thank you.
Thank you. Thank you, Dr. Karishma.
Thank you.
We shall move to the next talk. Arun, can you please share the CV of the chairpersons? So we have Kavita ma'am, Dr. Kavita, who is the chairperson, Urogynec and Pelvic Floor Repair Committee, FOXY 24 to 27. Associate Professor, Lord Buddha Koshi Medical College, Saharsa. She has received various awards like Padma Bhushan Kamya Bai Spate Award, Dheera Award in 2023. She has various credits to her. She is the organizing secretary of International Critical Care Conference, great environmentalist, member of Lions, IMA Foxy, IMS Foxy, ISAR. Thank you, ma'am, for joining us. And Arun? And we also have Dr. Meena Mahalingam, Associate Professor in Obs and Gynae, Chengalpattu Medical College, Secretary OGSSI, Co-Chair Urogynec Committee OGSSI, Member Urogynec Subcommittee FOXY. She has various academic activity like Master Trainer, EMONC, Faculty and Organizing Member in National and International Conferences, various memberships like FOXY, OGSSI, IUGA, URPSSI, and she has received scholarship from IUGA for attending IUGA conference, Best Doctor in 2024. Over to you, ma'am, to introduce our speaker, Dr. Manideep.
Thank you, Arati, and thank you, Dr. Vijay Kumar and entire Kasaba team for giving me opportunity. So it's really wonderful, and I think urogynecology is much more popular and much more practiced as in South India as compared to North India. So really, you all are doing wonderful job. In fact, in my committee, though I am chairperson urogynecology, but I am learning many things from urogynecologists like Meera, Meena, Amita Jain, Vijay Kumar, and many more. So Karishma, so you all are perfect urogynecologists, and I think this is the time when we should be trained, because more and more women are living for longer duration and they are being empowered. They are coming. They are not nowadays being shy and say they are speaking to the doctor. So everyone should learn and everyone should be aware of the problems and exact treatment what should be given, especially in cases of body dysfunction, incontinence. Both are quite different things. And I think many of us are not aware what medicine or what molecule or what type of treatment should be advised. Every time we ask them to strengthen the pelvic floor muscle, but it's not in all the cases, especially when there is high tone pelvic floor muscle. In that case, we need to ask them to relax. So these are the things that we should be trained. And so urogynecology is much more getting popular. And I'm thankful to Dr. Vijay Kumar and the entire team who are taking such pain to conduct such type of webinar and every Wednesday. So all the best. And today, Dr. Karishma has given so much talk. This is a very tough and important topic, but she has made it so clear and simple. So she needs praiseworthy. And now second speaker is Dr. Mandeep Pai. Sir is very well known. He is principal of SIOM and JNMH Kalyani, West Bengal, recipient of IMA Doctor's Day Award, and ICOG Visiting Profession 2023, Dean Indian Academy of Obstetrics and Gynecology. And Sir has written uh, this book, Urogynecology Pelvic Floor Reconstructive Surgery, which is very popular. I think many of us are having this book. So how Sir gets time and to write this such a big book. So he will be speaking how to diagnose and manage this problem that is being discussed. So the dice is yours, sir. So please start sharing your slides.
Thank you, ma'am, for your kind words. Am I audible?
Yes, sir.
Yes, sir.
Yes, sir.
Something wrong with my camera, so let it be no problem. If you can hear me, it's okay. Let me just try for slide sharing.
We are very fortunate to have you, sir. You are an authority on the perineal injuries. We are very fortunate to hear from you.
Yeah. Thank you, sir. Thank you. Can you just tell me where should I click? Here, no? I should click
Slide
here,
Sir,
right?
your
share,
voice
sir.
is clear, but slides are not still sharing.
No, I mean,
Sir,
I've
you go
started.
to the center share part.
Share this one, right?
Share. Yes,
Yeah.
sir. You click it.
Now, yeah, then
You have to click your
Then
slides.
slideshow from beginning. Just share slideshow from beginning.
yeah, but to go to my desktop screen, right? This is the entire
Yes.
screen. This is the entire screen, right? Should I go here? Should I go here?
Sir, have you?
Yeah. Done.
Yeah. Started.
Yes.
Yeah.
Can you see now?
Yes.
Yes, sir.
Started.
Yeah,
Yes,
yes.
sir. Now it's visible. Make it slideshow, sir.
Is this slideshow now?
Yes, sir. Yes, sir.
Yes, sir.
Fantastic.
Perfect.
Oh, thank you very much. Okay. After the Karishma's very beautiful lectures, very elaborate one regarding the anatomy, risk factors, and all the classifications, we are coming forward. The next one is the evaluation management. This discussion will be really based on the IUGA guidelines on OICs, which published only just last month, 2026. So already discussed what is CPT, the complete perineal test, where the sphincter as well as the mucosa of the rectum, the bowel are involved. Okay, so this part I'm skipping because already Karishma has discussed very nicely. I just want to say one thing about here. When we said CPT, right, we should think that previously when we were old, when before the Sultan's classification, we used to know that there is acute and chronic. And the chronic cases we used to call it CPT. Still it is existing. In our periphery and others, many people, they still come back, they delivered many years back, and then coming back to us as a some other problem or this problem, we diagnose as a complete perineal tear. So that those things will be categorized under the chronic varieties. And incidence already she has said, right? Not much incidence we found in the India, but only this one is found in one study published from the South India, which is the 2.1% vaginal births. Yeah. Now coming to the evaluation part proper. My job starts. Okay. So first of all, there are some clinical symptoms are there which can really well tell us that what is this. So bleeding. Many of the time, if it is acute phases, they'll complain of the continuous or heavy vaginal bleeding or rectal bleeding. Pain, yes. If we inquire very properly, many times we find out that they are complaining of severe pain in the pelvic zones, in the perineum. Okay, and difficulty in passing stool or other things, they will complain. Flatus incontinence, that is a very common phenomenon. If not the stool, but flatus incontinence, many times we come across. Fecal, of course, not all the people they complain of the fecal incontinence, but some people they complain, and that varies in the different arenas. Some say if it is a liquid, it comes out, solid doesn't come out. Some say no, if it is semi-solid, it comes out. Some say even a solid also comes out. So these are the different varieties where they come out. And some say that, okay, if you feel like to pass stool, I cannot hold it. So these are different ways they'll come up, right? Yeah, this is one of the very important thing, and we should not forget it, that we must do a parectal examinations. The mean length of the anterior anal sphincter is about 2.5 to 3 centimeter, corresponding to the distal digit of our index finger. So we need to know that what is our that much, and accordingly we can just measurement to be done. Yeah, there is a structured rectal examinations. Of course, I will be showing one structures format has been published in this Ayuga article. I will be showing that. Anybody can show that one, but that is very exhaustive and very small in the fonts, so maybe difficult for you to read over here. So that's why a little bit of, you can say, excerpt of that, and whatever we did till date, that just separate the two valves by your one finger, maintaining all the aseptic and antiseptic precautions. You can just put your index fingers inside the rectums and try to elevate it and move it from the side to sides, and it will continue down to the anal verge. And furthermore, the third or fourth digit, that is the fourth digit, the CPT, may be present when there is an intact perineal skin also, because it is not actually present, but apparently it looks like. So our eyes, we should have an eagle's eye to find out that actually where. Yes, sometimes I find out that a very thin layer of the perineal skin is existing. So in that case, though it is a stage 3, but we may think it is a stage 4. That does not make any difference also, I will tell you again. Because it is already a dictum is that if we have any doubt regarding your things, then you can upgrade it, because you will do better surgeries. You will not miss. Already Karishma said, no, if it is 3C, if it is a 3A, there is under time, you can do the operations and the other thing. So you will be sending the patient for the future incontinence. So in that case, it is dictum that better you can upgrade it instead of downgrading it. Yeah, this already Karishma discussed. Just see here that this is the areas what she said, the it looks as the like chicken one, right? And this is IS, and this is the regarding beef one, which looks at the ES, external sphincters. Already it was been discussed, but anyway, just for as, because when you'll be going for the operations, it is little bit important, right? See here, these are the 1, 2, 3 areas, and up to this much 3A, 3B, less than 50%, more than 50%, 3C, internal also involved. And these are the third part of the your external sphincters. And you can see this one also, because if you understand this, will be very easy for us when we'll go for the endoanal USG. See here, this is the your external, this internal, and this is the mucosal parts. Okay. So this one less than 50%, more than 50%, almost touching the internal, but internal is not affected, and internal also been affected. Now here the anal mucosa also, the rectal mucosa also been affected. Someone is doing some these lines in the slides. If some, can you just stop
Sir, it's
this?
fine, sir. It's fine, sir. You go ahead, sir. I will check it. I'll check
fine.
it, sir.
Yeah. So yeah, this one I'm not going. This one I'm not going. Yeah. Now coming to this techniques, how to diagnose this? Okay. This is by Sultan's pill rolling technique to identify the integrity of the anal sphincters. What is this? Nothing but look at here. What has been done? See here. This is the anal sphincters areas. This picture is from by Sultan. Okay. This is the anal sphincter areas. Put your thumb inside the anal areas and the thumb above this. And you just roll in between your two fingers. And you can find out the integrity. That means if it is absolutely fine, you will just flick off your fingers. But if it is not fine, tear is there, your finger will feel that some depressions are there, some gaps are there. It's very easy to find it out, but a very valuable tricks. Next is that the finger lift test. Why it should be done? You know very well that that is superficial transverse perineal muscles, which is going like this, which attachment is towards the lateral sides, and the sphincter is like this. Right? But sometimes, at least for the EAS, external sphincter, we sometimes miss this one with this one because they are very much nearby to each other. So to understand that it is really not the SPATM and these EAS, what you do, the torn end, you hold it with the 2 Ellis forceps and then put your finger inside and lift it up. If you find the gap is that your fingers can move up, that means the ES has been torn. But if like that you hold this two and you are lifting it up and your finger is inside, but you are unable to lift this area. That means what structure you have folded lifting up, actually it is the superficial transverse perineal muscles. Here the sphincters are intact. So this finger lift test, again by the Sultan, this is very helpful to differentiate between whether the social transperineal muscle is injured or the ES is injured. Okay, right. Yeah. Now these are the clinical examination we have done, but is it enough? Yeah. I am not saying that our digital rectal examination is not that much powerful. Definitely, it's very powerful, but still, in some cases, you may need to have the assistance of some of the investigations. Especially, this one is very good. Abdominal ultrasounds. Okay. But it is not easily available everywhere and little bit of costly. And it has the property that you have to put the probe inside the rectum. So a little bit of invasive in nature. Also, along with that, if you do the anatomical manometry, so typically you can find the functional part. That this one will give you the physical parts and this one will give you the functional part. Okay, these are the different categories: advanced, essential, desirable. Yeah, let us see the desirable because it's not always possible to get all these things over here. So digital rectal illumination may be used together with this thing. You may get one, but this one it is available. The transperineal ultrasound. What is this actually? You can just use the normal ultrasound probe, which is available everywhere in all the setups. And through this one, you can put your probe over there. With that same probe, you can assess the sphincters. But definitely, the other one is better. But if it is not available, you can use this one also. So these are the few of the pictures. These were the abdominal UHC or the you have to put it go inside. Right. So this is a little bit of invasive in nature. Multiple, but this is very good because you can see the multiple slices can be taken, different planes you can do it. And this is a normal one, right? These bright colors. Okay, this is the external sphincters, and then this is the dark color. This is the internal sphincters, and then this is the epithelium or the mucosal part, and this is inside the lumen where the probe lies. So if you can understand that, and this is the interface with nothing but there is a probe outside that in between the probe and the cap is there. No, will you put the condom and other things and all, right? And if you don't put also anything, but thing is that this is the junction between these two. So our target is to look here for the mucosa, look here for the internal sphincter, and look here for the external sphincter. Okay. Now look at here. So this one is yes, external sphincter, and black is the internal sphincter and the anal mucosa. Look here. This one, it was going up to this much, but beyond that, you will find the black. That means what? This area is up to this part is intact, yes. But if you look here, the ES is deficient. Look at here for the IAS. Up to this much, you can find a very good breadth of the IAS, internal sphincter. Beyond that, you're not finding anything. That means the IAS is lost over here. But the anal mucosa, you see, this is okay. You are not finding that much of problem with anal mucosa. Yeah, now this is another picture you can find out, very good one. Okay. See here, this is a normal one. Okay. This is the EAS, the bright one. The blackish one is the IAS, all around is present. And this one is the mucosa, all around present. Now, if you look at over here, we written over here also, okay. She was asymptomatic for anal mucosa. See here, she did not complain of it, but there is a hypoic defect of 42 years. See over here, this area. From here, the brightest areas are present. But if you look at over here, not exactly this homogeneous things is gone here. Okay. So, little bit of ES is gone there. And then for the C1, see here, this patient also 1063, 9 to 2 o'clock. Oh, no. Yeah, okay. See here. This one, quite a good amount has been lost. Right. Even to some extents, right. So these you can find out very well. This picture you see here on the top, this area, the ES has been lost. But inside one, right, see here, the IS also lost. So these are the different pictures you can find out that biological, by endoscopic ultrasound, you can find out that the different varieties of trauma. I was telling, no, everywhere that probe may not be available. But see here, transperineal USG, you can simply use this normal probe, right? And you can use this one. And as it is available, at least if it is not that up to the mark of the endonal USG, but still you will get a good ideas. Okay. So this is the rectum, this is the vagina uterus, right? This is the IAS. So like this, you can find it out. See here, this is the anterior, this is posterior, right? So this is the IAS. So this thing you can find it out. Okay. Yeah, coming to the functional aspect, manometry. We can go for the anatomy manometry. This is the probe. The balloon is trying to fix it over there. And this area we are with the sensor. So this sensor will help us to get the information about the IAS as well as the EAS. Right. This is the different graphs of the anatomy manometry. If you look at it here, this is for the rectal pressure, and this is giving the anal relaxations. Okay. Usually, the pressure should be, rectal pressure should be more than 40 mm of mercury, and anal relaxation should be more than 20%. So it is good one. In the type 1 variety, pressure is still okay, good, more than 40%. But there's a, you can find out that this is little bit of contraction of the paradoxical contraction we find it. Type 2, pressure is fall, right? Less than 40%. See here, these bright colors are not there. Okay. And again, paradoxical contraction. See here, this is color, and see the color changes. Type 3, pressure is less than, more than 40, because you see the color has come up. This color is not there, but color has come up, so 40 is there. But incomplete anal relaxation. See, this is relaxed, but this is not relaxed. Okay. Type 5, see, again the pressure is not good, and again here we cannot find the relaxation. So different way of finding this one, but again, if you are not having this one, your digital evaluation should be done along with the transperineal USG. By these two also, you can generally diagnose many conditions. What are the objectives? To confirm your diagnosis, to evaluate the structural integrity and functional capacity, to better to give the recommendation. Yes, the anatomical symptoms, even some people may not be this normal, our operation may not be 100% corrective, so we may go for the other part, second information others. And the last but not the least, the most important part, whether I should say, the counseling. Because you can tell the patient that what is the level of the injury is there, or whether any injury is there or not, whatever things, and then accordingly you can do the very much good counseling, and she also knows that how much she can expect improvement. Yeah, but for pregnant women, little bit of different, because assessment should be done after 20 weeks preferably, because the risk of spontaneous potential termination of pregnancy, those, because before they were diagnosed, so what should be done? Very difficult to do any other measures and all. And for the time required for arrangement of any special assessment or other things, it can be done very easy well. And giving a long time for the adequate consideration options, because she can take the options, because after 20 weeks, the chance of viability of the fetus is more. So that is the one point. And last of all, again, that if at all to be done, or that CS to be done or not, those planning can be done. Yeah, what I was telling that this is already everybody can have the access of that article. And if you find out that this is the component of the postpartum assessment of the women with obstetric associated injuries. This is one page on the short-term and long-term sequelae. This is on the impact on the quality of life, pelvic floor assessments, family planning, then the neonatal symptoms, pelvic floor dysfunction, sexual dysfunctions, quality of life, mental health, patient satisfactions, and general appearance, because they have some problem with this body image also, this thing. Then inspections of the perineum, we can how we are finding it out, neurological examinations, speculum examinations, and then the digital examination, lactovaginal GRE examinations. So all these things very nice form it is given. So you can take the help of this, and Joliet, you can have your own institutional setup. Whatever available in your setup, accordingly you can have your own diagram or flowchart or according to your setup. Yeah, now coming after the evaluation is done, then now we are going for the treatment part. So mainly the operation is we do usually, but initially the counseling is very important, and taking the informed consent, because you need to tell them what is what, and then accordingly. And because you know the persistent sphincter defects on the ultrasound is 55%. This is very important. I will come to this also. What is the persistent sphincter defect? And I will also found to the 38% even after repair also. So these are the things which needs to be informed to them, so that to avoid the litigations and others. And preferably, it is better to have the documentations, because in the present era of litigations, that is the one slide is then the last part of the litigations. So keep a proper documentation so that you can avoid the cases. What are the general principles? Yeah. First of all, the trained person, right? If you go through the Ayuga, we had our perineal 5 workshops are there, perineal injury episiotomy workshops, certificate course also there. Whoever interested, Julia will go to the Ayuga assets. You can just make yourself certificate course holders. And repair of the perineum should be undertaken as soon as possible. A delay can be considered. Yes, I will come to that also. Timing. Yes. And rectal should be performed for each and every one, and accordingly you will diagnose what is the degree, and accordingly plan it. Yeah, these are the pictures by the Sultan, right? For the my concern will be all on the complete perineal tears. So I see the 4, right? If you see here from the top, if you look at here, see everything is gone, even up to the anal mucosa. Okay. And the inferior, if you look at this, you can find out like this. Even the anal mucosa also gone, and all other things are gone. Again, it is available in the perineum.net. In the Ayuga Absolos is available. The pig model. You see here the external sphincter, the raw beef areas, internal sphincter, the whitish areas. Okay, and anal epithelium. Just in between these two, see, you can find out that there is a gap. So which can make you understand that this top part is the internal sphincter and below part is the anal epithelium. Right, setting. Now coming to the setting. Desirable. What is the desirable? either general or regional anesthesia, right? Good lighting, proper equipments, and aseptic conditions. But many of us, you know that in our busy labor room, always and many times we need to repair in the labor room itself. Maybe it's difficult to shift the patient, right? So many practical aspects are there. But in that case, we should ensure that the proper pain relief. Yeah, you give her some painkiller injections and others, and good light. That is very important. Otherwise, without having a good light, may not be the OT light, but at least the labor room can have a good lighting system. So there, with the good lighting and equipments, yeah, we don't need the very high-fi sophisticated equipments, but the whatever is needed, if they are not very costly also, you can jolly well keep those things in our labor room whenever needed. It can be used, and aseptic content definitely needed. Suture material, what to be used? Anal epithelium, 30 polylectin or polylepacron. There is the monoclus, and this is polydax. Usually, I use this polylectin only, the Vicryl. So I am comfortable with this 30 polylectin. Sphincters, ES or IS, 30 PDS or 20 Vicryl. I mean the polylectin. One very important part, remember that surgical nurse should be buried beneath the superficial to the perineal muscle. That means better not to put it inside the lumens and others, because there is chance of suture migrations. Yeah, this is same thing along with the technique. Anal epithelium, yeah. So there was the 3G polylectin. I prefer this polylectin. So let us concentrate on this one. This is better. One standardized thing is better. 3G polylectin. Continuous non-locking sutures. Yeah. Anal epithelium continuous non-locking suture should be given. And then the internal sphincter, either 30 PDS or 20 this time. I use this thing. I use 220 polylectin. End-to-end interruptus mattress sutures. EAS, either PDS or 20 Vicryl. I mean, it's a polylectin. End-to-end or the overlapping technique. But this is not possible for the partial. But if it is a full length, you can go for end-to-end or the overlapping technique. Figure of 8, very important, though is small font, but figure of 8 suture should be avoided. And perineal muscles should be reconstructed following to the anospheric to avoid the deficient perineum. Right. Yeah, I was telling, these are the few of the instruments in the perineum.net, and these are the our Professor Abdul Sultan usually use these things. Right. It's a very Whitelander retractor, very good instruments. If you have this one, it's a self-retaining also, right? So very good exposure you can have. And other things are very small things. Tooth forceps, stitch scissors, needle holder, McIndoe scissors, artery forceps, any forceps. And this is available in everywhere. This one may not be available everywhere. If not, you can purchase one or two. Or if not, also okay, with other things you can do. But these are the available. So we should have this thing, labor room. I think all of us have. Yeah, now coming to the, started. The proper technique. Usually you can give, this is, this case actually was a chronic variety, right? Okay. We give the inverted U incisions. Actually, see, these are the two dimples. These two dimples are the external sphincter. Okay. And then you can give an inverted incision starting from this one dimple, go like this and come up to here. This area should be the junction of your this one and this one. This is the vaginal mucosa, this is the anal epithelium. Right? And then from the center of this U, extend the incision toward the vaginal mucosa. And after that, you can find out that we have already exposed all the areas. This is your external, this is internal, and this is the vaginal mucosa is gone. Right? I'm sorry, right? Anal mucosa is gone. So first, to start with the rectal mucosa, it is a continuous non-locking sutures. Okay, and this is, I find, is very important. You may take it, you may not take it, but for my practical purposes, I usually take a one bite, little bit distal to the apex, because missing apex is dangerous. After repairing everything, if I find out the apex is missed, it's very difficult to repair at that moment. So it's better to take one bite just distal to the apex. I'm not telling take it so high up, just distal to the apex, so that you are always be sure that you have never missed the apex. Okay, by this way, continuous locking suture, that all of you know it. Just complete that one. For the IS repair, see here, this one IS we are repairing. Okay, so this is Sultan. So interrupted mattress, right? He has used 30 PDS, but I use the 20 polyglactin. But it's up to you. Anything you can use. ES repair. For the ES repair, this is the two different techniques are there. Okay. Two hands. These are the just to make you understand that. See the 3 o'clock when you're doing end to end, these 3 o'clock take a bite and 3 o'clock take a bite and suture them together. 12 to 12, 9 to 9, 6 to 6. So that the perfect alignment will be there. Right? This is the overlapping technique. So for this, you need to release the external ES quite a good extent and then bring them towards the opposite sides, one above another. And from top, you come down, out, then again go in, out, and then tie together. Like this way, 3. Okay. Overlapping technique. Yeah, this is again Sultan's picture. See for the overlapping technique. Right. So this way he has given. After that, it is he has used in each layer he used 2, 2 and 2, 2. But anyway, you can use 1, 1. I used actually 1, 2, 3. But he has used 2 layers, but each area is 2, 2. That was a very good technique. Yeah, see here, this is the below the left ears has been brought to these sides, and top the right ear is taken up to this much. So quite a good amount of area overlapping is present. So this is very important, so that you need to release quite a good amount of the ears areas, so that you can do this overlapping. Right. That is one of the very important part. Yeah, if you want to compare these two, the overlap and the end-to-end, the Cochrane review, which is done by the Fernando R.J. Sultan and others, Catel C and Rani Thakkar, is a 2013 Cochrane Decision Review. At 36 months, there's no difference between these two techniques regarding the flatus incontinence and the fecal incontinence. So now you can understand that if you find this difficult, even maybe it is a CPT, but due to this loss of fibrosis and other things, you are unable to do a good dissections and not getting a good amount of the leg to do the overlapping. If you do it in the end-to-end also, nothing to worry much. In the long term, the outcome is almost same. Okay, no difference. Of course, there are a little bit of difference there when you are doing the repair. What are those? For the overlap repair, the greater surface area of the contact between muscle ends. Because as you have seen the previous one, right? But here it is not, because you are just doing the two ends are coming together, right? Incomplete appositions, this is not possible because you are doing a quite a good amount. But here it is possible because as I have shown, that's why I write those 3, 6, 9, 10, 12, it's purposefully right, because so that you can understand what to wear to anastomos. Anal canal shorter length, that is not possible, but may be possible sometimes. Partial thickness tear, yeah. Here though, overlap is not possible. You have to do the end-to-end only. But with full thickness, overlap also possible, end-to-end also possible. Okay. So after completing all these repairs, then you repair the posterior vaginal mucosa coming from top. Posterior mucosa is completed, but now we have to repair the social transverse perineal muscles, right? It is mandatory, otherwise we deficient perineum. And then the bulbospongices, because they are coming like this. This one is going towards laterally like this, and bulbospongices is coming like this. So we need to identify all these muscles separately. See, this one external sphincter, this one social transverse perineal muscle, this is the bulbospongices. If you do the dissection, you can jolly well find it out. Everybody can do it. Very easy. Okay. So when you're repairing all this, then just repair the skin. I prefer that you should do the subcuticular sutures. Okay, this is very good one. And see, ultimately you can find out like this. The perineum. Anas also looks very good, and quite a good amount of perineum will get it. Yeah, this another entity is there, the buttonhole tears. What is this? Is the full thickness tear torn of the anal epithelium. Is right. And in that case, the anal epithelium should be continuous non-looking sutures, not secured on the vaginal aspect. Very important, because otherwise there is problem because the lumen problems are there. Rectovaginal fascia, above that, interrupted mattress or continuous with 2030 PDS. Okay. But anyway, as I said that if you're having the PDS, use, right? But vacuole also, I mean, the polyurethane also is not a, that was a good one. I have used many cases the polyglactin. Overlaying vaginal skin, continuous long 20 vacuole. Yeah. So this is regarding the, okay, now this is not the CPT, but just before one less than the 3C repair. Let me see, can I play it? Achha, okay, it's play. Okay, so see here, why it is, because the small area of the perineal, this thing you can see now, the blackish area, was there. So, yeah, see here, catching the torn on the, yes, this is very important. You can generally find the puckering was there inside. So that's the idea of the, actually, the ES has been torn inside. So you can find it out that. And now, with that, we'll give a, yeah, incision. Inverted U incision will be given over there. Junction of the vaginal and the anal mucosa. Yes. After that, we need to dissect the posterior vaginal mucosa that everybody knows. This is the anal canal. Yeah, just put the scissor inside. That everybody is doing like this. Yeah, this holding is important because then your the excision will be at the center itself and the straight line. Yeah, this from this side, social transparent, and from the top, the bulbous system. Yeah, this is the formation of all the 6 muscles fibers, including the levator line. They comes and meet here and forming the perineal body or the central tendon of perineum. Yeah, now we are dissecting the action and anal sphincter. This is important. The counter traction. See, this counter traction is very important. That makes the area taut, and you'll find that this area, what is the areas? Fibers can be seen very nicely. See, the fibers can be seen very nicely. And dissection become very easy for you. So this one is traction and this one is counter traction. So this makes your dissection very easy. So right side you are doing. Now trying to fling up the left side. Same thing. Traction, counter traction. Now see this, yeah, see, you can see here. This area, this is the IAS. So once you have exposed the area, ES has gone separately. The other thing can be seen nicely. And actually kind of a triangle shape are visible and some torn fibers are visible. So we are trying to repair this one. Yeah, as I said, no, I use the 20 the polyglectin. Interrupted stitches. Yeah. Now, if the end-to-end was given, it will be like that. Now, if they do overlapping, that will be like this. Yeah. This is one very important step, putting your finger on the rectum. And while you are doing this apposition, this is the overlapping technique. So you try to understand that what will be the postoperative outcome, right? And then also that will give you a clue that how much tightening you should be doing. Or is it loose? So all the things, just by doing this tightening and putting your finger in the things in the rectum, the anal canal, it will give a very good idea. And you can predict also that how far good will be your postoperative result. See, the pier finger is still inside, which gives you a clue that, okay, you have achieved the optimum tightening. Not too tight. For the second and third, fourth bite from below to above, second one. Same thing here, I am using the polyglectin. This is the third stitch. Okay. Now the suturing of the social transverse perineum, then the bulbospongiosus, perineal skin closed. Ultimately, is the end result. Okay. Now coming to the timing, when to do the repair. If you miss the primary repair, traditionally you say that wait for 3 to 6 months to allow neovascularization and the resolution of the inflammation. And it reduces the risk of wound complications such as the infection, abscess, and fistula formation. This is a traditional teaching. But nowadays, the delayed primary repair beyond 70 has been attempted. Early secondary primary repair within the 14 days post has been repeated. And Wexner fecal incontinence score shows that 4.1 to 1.1. I just tell you that 1 to 4 is mild. So it is just 4.1. So that means what? By doing these two repair also, and the 1.1 for the traditional varieties is not that much problematic. It's a mild complaint is coming up from the patient. So if the patient is very much worried, mentally traumatized, and in those cases, if you think you may do the this thing early repair, then delayed primary repair, early secondary repair, it can be done. Now coming to the perioperative management. Assessment before that, overall health condition, medical history, is there any comorbidity, and detailed examination, and documentation. My last slide will tell you why it is important. Intraoperative, broad-spectrum antibiotic, very important, because otherwise the chance of subsequent infection is very high. Now coming to the post-operative management. Laxatives for 10 to 14 days is better. How much? 15 ml 2 to 3 times per day. Okay. When to start? You can start from the second or third day when we are putting them for the for me to when I initially I keep it around 24 to 48 hours for the IV fluids, depending on the how much extent you have done. And after that, when we start with the liquid debts, from that time itself, I put them on the laxatives. So indwelling catheter for 12 to 24 hours. Good analgesia is very important. Seize bath Yeah, that will reduce the inflammations, local inflammations. High fiber diet, that will help in forming the stools so that the constipation can be avoided. Okay. Painful exercises for 6 to 12 weeks and early wound review. Bladder care is very important because many times bladder, because the locality are painful, so they feel like to not to emptying the bladder and ultimately the blood distribution occurs. So you can use the bladder scan. It's a very good tool to find out the how much is residual urine, and then accordingly you can manage it. Physiotherapy, very important, very important. And if we have the physiotherapist in our center, and if they can guide them, it is more beneficial. Guided physiotherapy is always better. Outcome divided in two parts: short term, long term. Short term, wound infection, dehiscence, depends on the if it is a operative vaginal birth, higher body mass index, smoking. These are the things which causes more of this. But long term, recurrence in subsequent birth, anal incontinence, this can occur. Complications, perineal pain. Yeah, many people they have complained of perineal pain, right? And because of that, there is sexual function is difficult, and many people they don't have intercourse even for years. They said no, it's very difficult, it's very painful, and like this also. 4 years after measurements, is saying that nearly half and 1/3 of the male partner they meet the criteria sexual dysfunctions, right? So you can understand that. Fear of incontinence, yeah, and pain limiting the intercourse. Psychological impact, body image. They feel like that my body has been distorted, injured. They think that their genital anatomy are totally worse. Worse nightmare than expected. Well, I've been crushed. This is the post-traumatic stress disorder. It may invade the depression also. When to call for follow-up visit? ACG Australian guidelines, they said 1 to 2 weeks, call them first. RCG said that 6 to 12 weeks. German guidelines says that 12 weeks. But anyway, up to you. For us, we usually call them after 2 weeks. The first visit needs to come after 2 weeks. Long-term management, bowel control issues, bladder control issues, pain management, dyspareunia, postpartum depressions, issues with lactations, fistulas, anal sphincter, deep separations, those are the problems. Yeah, I was telling the persistent injury. Let's come to here. To understand whether really, because when they'll come for follow-up, when we'll be doing this examination investigations, if you can do the ultrasounds, 3D endo-anal ultrasounds, or if not the transperineal ultrasounds, right, 4D or 3D, that will find out that many people they have the residual these things, right? So this is very important because many times we find out that along with the anatomy manometry also, get to know the functional aspects. So many people see that almost 55% people they are having this problem with persistent injuries are there. After 1 year, you can find it out, 55%. That's the importance comes regarding the counseling. Because when you understand that, okay, they are still not that totally all right and other parts. So let us lesser sequelae may be there. And in that case, we need to make them understand that in the subsequent pregnancy, the cesarean section may be needed. And that was an elective cesarean section, not a emergency cesarean section. So not always mandatory, but depending on the how much defect persisted, we have to tell them. Yeah, subsequent birth, overall recurrent risk is the 6.1%. We need to tell them, and it needs to be documented also while you are doing counseling. Very important. So be aware that, and by our symptoms as well as our assessments, and if available, then with this one you can do it. Can it be prevented? Yes. We can do the antenatal perineal massage in the 3rd trimester. We can do the perineal massage during the 2nd stage of labor. Warm compression, 2nd stage of labor. Perineal protections at crowning. We can take a help of the other colleague. And in the NHS trust, they have done this, the care bundle initiatives. It's available in the net also. If possible, you can take this help of this care bundle initiatives. You can apply this one also. Yeah, this is one study published Ayuga journals. Okay. What are the conclusions? The advanced maternal age, increased infant body birth is an urgent category of the initial CS. Increased DOSA VVAC, whereas the ML is protected. So, if there is a VVAC, still there is a chance that there is a chance of this one. And in that case, the midurethral episiotomy preferably should be done to avoid this problem. Yeah, now we are coming almost towards the end of my lectures. Medical legal issues, very important. The present era of litigations, they are making us very much important. That's why the documentation, I put it the topmost part. Whatever you had been, whatever you are saying and other things, make it documented. And it is, the documentation should be only signed by the patient herself, along with her, who is a witness, either husband or anybody who is there, relative is there, and the should be countersigned by the doctor or the midwives or anybody who is doing the counseling. He or she also should the countersign. So these documents is very important. And if you have the structured counseling performer, that is best. All the institute can have their own performer. And we should have a audit, periodical audit, which also help us. And yeah, the institute protocol, I already said, you can have your own protocol. How to avoid litigations? We should have a good knowledge about the OSCs and how to prevent diagnosis management. Right? Standardized training. As I said that already PI training is already there by the conducted by the Ayuga. Like this, many other trainings are available. We could have the trainings. Assessment tools, right? If we already discussed till now, what are the tools available? We should have those things and we should have the competencies. By this way, you can, if you already documented that we have done all these things, yeah, completion can occur, but you can avoid the litigations. So the take-home message is that early diagnosis is the key, so that you can do the proper way of treatments, repair by a trained person, right? And structured follow-up, and ultimately causes the better outcome. Thank you very much for your patience hearing.
Thank you, sir. It was very elaborate, brilliant presentation. So I think you have explained everything. So those who have joined must have learned a lot from this presentation. You have explained exactly the teacher, every point, how to examine, how to see what is the importance of, ultrasonography, especially 3D ultrasonography, rectal manometry, which can detect the pressure and function of the inner sphincter rectum. So every point has been covered. The repair part is also covered very well. So I think most of the gynecologists who have joined, or the students who have joined, must have learned, and it's very common. It can happen with every clinic. So everyone should learn, and this should be practiced by gynecologists. So I think the slides were very good, along with the video also. So thank you so much, sir, for giving this opportunity and for such a brilliant presentation. Sumina, you are here.
Thank you, ma'am. Thank you, ma'am.
Thank you, Mandeep sir, and thank you, Kavita ma'am. Thank you, Vijay Kumar sir, Chairperson KSOGA, for having given this wonderful opportunity. And Mandeep sir, it was a very practical and enriching session, and I'm sure that it will translate into better clinical practice for all of us. So you have beautifully highlighted all the diagnosis and successful management about repairing each and every tears, and about accurate diagnosis. That is very, very important, because if we do not diagnose properly, we are not going to do a meticulous repair. And also about follow-up and the litigation, documentation, everything you have dealt in detail. And that is how we are going to ultimately restore the women's quality of life. Thank you, sir. And also very good take-home messages.
Thank you, ma'am. Thank you.
Thank you, sir. Thank you, sir. This, I should say, encyclopedia on the complete perineal tear. So A to Z you have covered with practical aspects. Sir,
Thank you,
one
sir.
question from
Thank
my
you, sir.
side. One question from my side.
Yes, sir.
So, what is the percentage of your complete perineal tear repair in which you will be able to identify the internal sphincter and repair it, sir?
Percentage.
Yes. How many cases you will be able to confidently identify the internal sphincter and repair it, sir?
Actually, see, exact percentage is very difficult for me to tell you, but I can just tell you
Yes.
that what the technique I apply to identify the structure.
Yes.
So first of all, my policy is that external sphincter, I try to, as I said, no, I prefer the overlapping technique. So I usually do
Okay.
the good amount of separation for both the sides. Once the
Yeah.
both the sides are widely separated, and you hold it to either Ellis or Babcock. Babcock is definitely better because that gives a less crushing injury to the tissues. But if you have the atraumatic Ellis, I don't have atraumatic Ellis, but if you have the atraumatic Ellis, that also can be used. Okay. So one thing is that after separating these two, if you look at the center, topmost bottom is the anal epithelium, but just top of that, you'll just put the light over there. I mean, your OT light is there, no? You just put the OT
Yeah.
light over there. Once you put the
Okay.
OT light over there, you will find that some glistening areas are there. And that glistening
Okay.
area is nothing but the internal anal sphincter. If that glistening area you find any tear or any other thing, then Julian, you can do the repair.
Okay. Okay. Sir, one more thing. Suppose if we have not identified the internal sphincter, this is for the delegate's purpose. If we have not identified the internal sphincter, can we go ahead only with the external inner sphincter repair, or it's a must that we have to repair the internal inner sphincter as well?
If there is an injury in the IAS and if it is not repaired, definitely in the long run, there will be anal incontinence. Short term may not be there, but long run patient will come back with anal incontinence. So it would be wise
Okay.
that look for it.
So it is the
Sure.
muscle of continence. Internal anal sphincter is the muscle of continence. So if we do
Mm.
not repair internal anal sphincter, then the patient will automatically develop flatus incontinence,
Yes.
also to the liquid stools. So identifying
Yeah.
very, very important.
Yeah. As Dr. Meena said, the anal continence is one of the most complex the anatomy in the entire body. So each of the sphincters are very vital. Internal sphincter for flatus and the external sphincter for solid stools. Thank you all for joining and enriching us with this knowledge. Over to you, Dr. Aarti.
Yeah, thank you, sir. Thank you to all our eminent speakers and our chairpersons for joining this session. And special thanks to all our delegates for their and making it a grand success. I hope this session has, I hope not, I definitely feel this session has made us more confident to handle this challenging situation. And I also thank our President, Dr. Rajeshri Kalladi ma'am, and our Secretary, Shobha ma'am, for giving us this wonderful opportunity. And thank you, Vijay sir, for giving the opportunity.
Thank you. Thank you, Dr. Aarti.
Thank you. Thank you. Thank you, sir. Suman ma'am. Hi. Thank you for joining us.
Yeah, thank you. Thank you. It was a very good session. Very practical points.
Yes.
Thank you very much.
Namaskara, madam. Namaskara, madam.
Namaste, namaste. Can I ask one question still when I had some
Please,
doubt?
madam.
See,
Please,
the
madam.
first surgery, primary surgery, you have not repaired the internal anal sphincter and you have just left and she is complaining subsequently. She comes to you after 6 months saying that she is having anal incontinence. Then it is very difficult to repair. I think it becomes fibrous, the tissue becomes fibrous. It's difficult to identify the internal anal sphincter. So I think the first surgery is always the best surgery and it definitely has to be done by a senior consultant, I feel. Then what is the solution if she comes with anal incontinence subsequently after the primary surgery, sir? and you're not able to say, look, it's difficult to identify the internal anal sphincter.
Madam.
Dr. Mandeep, sir?
Yes. Madam, definitely that is a very difficult situations. But still, if we do the proper anatomical dissection,
Yes,
slowly, you will be able to find somewhere where the IS is missing. But before that, I should prefer that in such cases, if we have the facilities of the abdominal ultrasound, better to do this one so that you can know that actually which, madam, you just see the clockwise in the watch, no, clockwise from
yes,
3 to 6. If you know that from the before and that this area has been damaged, then we will focus on that area and do the dissection on that area. If not the internal USG also, at least if you do the transperineal USG also, which will give us a clue that, madam, that area has been damaged, then we will focus our dissection on that area and definitely we will be able to find it. Okay, I am agree with you, madam, that it will take some time. It is not like an easy that easily will find out the IAS, but if you take time and do the meticulous slowly, if you go inside, it will be, we will definitely find out the IAS.
Yes, sir. So because I saw one or two cases like that, where the patient primary surgery was not satisfactory and they have come and they are really suffering. Till second surgery also done by somebody else, that also failed. Very difficult situation, sir.
Yes, madam. Definitely. Actually, that's why, madam, the primary injury has to be identified properly and to be repaired. As you mentioned, if there is any suspicion of the third-degree perineal tear, then immediately we have to shift the patient to the OT, because if we have the good anesthetist backup and if the exposure of the wound is proper, then the repair would be better. So the results would be better. So if it is failed, definitely she has to undergo the surgery. In that time also, the experienced urogynecologists, if they repair the wound, it would be better compared to the other gynecologists.
Thank you, sir. Thank you for the opportunity, sir. And congratulations for the wonderful webinar.
Thank you. Thank you all.
Thank you, madam.
Yeah.
Is Hiremat sir there?
Should we exit, sir? Any other questions?
Yes. Yeah,
no,
it was a quite interesting discussion.
Yeah, I
Please,
just
madam.
want to,
Please, madam.
yeah, I just want to say Dr. Vijay Kumar sir and team have done a wonderful job getting such a topic which really needs attention, which really needs everybody to understand this. And the prime doctors, if they understand this a little more detail, I think we will have a better answer to the problems which exist in the patients. Thank you so much. Thank you. It was wonderful.
Thank you, madam.
Yes.
Thank you, Dr.
Thank
Karishma.
you.
Thank you all. Good night.
Thank you. Thank you.
Thank you all. Thank you.
Thank you.
Thank you. Thank you. Good night. Good night.